paid the referees to have a good chance. So why perform an open lateral Z? You already had before from Tom a lot of things regarding the battle between open and arthroscopic lateral Z. So I will not add anything new on this. Just brief notes of history. As you probably know, Latarze was a French surgeon born in Lyon in 1954. For those who don't know, he was not an orthopedic surgeon, but he was clever enough to develop such a nice operation 65 years ago, 66 years ago, which is still in practice. He was a thoracic surgeon, but it seems that he is more clever than we are as orthopedic surgeons. So for a mini open lateral Z, you don't need something special, you don't need special equipment, supine position, 5 to 7 centimeter incision, a classical decto-pectoral approach. You have to split the subscap between, as you heard before, the upper third and the middle third. So this gives you the ability to provide the hammock effect of the inferior part of the subscap. This is probably the most important point at my perspective in order to avoid what we discussed so much before, the complications, especially the musculocutaneous nerve, which is most commonly damaged in this procedure. And this is an excellent anatomical study from Laprade and his group, which defines very clearly the distance between the conjoint tendon, the coracoid process, the musculocutaneous nerve, and the axillary nerve. And I strongly recommend everybody to read it because it gives you a very good idea of the distance between the neurovascular structures and the conjoint tendon and coracoid process. Then what you have to do is to debride the glenoid and fix your graft with 2 screws. It's really a very quick operation. Most of the times it takes you 35 to 45 minutes. And regarding the indications, we heard so much this morning. And what I have to say is that indication differs amongst surgeons. Everybody can use it in the way she thinks is the right way to do. Of course, an anterior inferior glenoid bone loss between 13 and 25% is a very, very good indication, probably the best indication. And of course, other relative indications like combined Hill-Sachs lesions and glenoid bone loss, poor quality of the capsule and ligaments, which is also a very good indication. Revision surgery, probably it's one of the best indication. Extreme contact sport participation and Hagel lesion as well. These are some examples of the lateral Z procedure, open procedure, combined Hill-Sachs lesion and glenoid bone loss. Revision surgery in a 23rd-year-old basketball player. He underwent this type of operation before. Indications also based on some scores. We heard also the instability severity index score. However, very recently it was described the glenoid tract instability management score in arthroscopy 2020, very recently by Giovanni Di Giacomo. And based on both scores, the threshold is 4 points, and up to 4 points you have to do an osseous reconstruction. However, based on that, almost every patient needs a bony reconstruction based on the instability index score. And the good thing with the glenoid tract instability management score is that it leads to a few lateral Z procedures, and this is probably in the future something we have to keep in mind. Besides that, the indications is something that every surgeon has in his mind, like symptom duration, number of dislocation. Most of the surgeons are performing a lateral Z when there are more than 5 dislocation. Revision surgery, many surgeons, Hill-Sachs lesions, between 11 and 20% defect of the humeral head, and of course glenoid bone loss, especially when it is more than 11% to 30%. What about the ability of latter Z to cover such a big defect? We did a study published in Arthroscopy some years ago, and we defined that indeed the latter Z is a very good procedure to cover big defects more than 25%. Of course, it's a non-anatomic operation, but is it such a successful operation? Probably it's the bone effect, it's the ligament effect, it's the muscular effect, it's the combination of all these things. As we heard this morning, probably the ligament effect is even more stronger than the bone effect, but I really don't know which is the strongest effect of latter Z. So open or arthroscopic, how to decide to do this? I mean, scientifically, you have to base on the recurrence rate, the shoulder function, the complications, the cost, which is something that has not been mentioned in the previous talks, and of course the surgeon preference or experience. So to decide based on these things, we have to take into account the systematic review and meta-analysis, prospective comparative studies, retrospective comparative studies, and case series. So based on that, let's start with this systematic review and meta-analysis published in AJSM 2019. As you can see, it combines 6 clinical trials with almost 900 patients. Revision procedures, total complications are more or less the same, and recurrence rate. However, the arthroscopic procedure was a longer procedure, and with the open procedure, there was a lower rate of persistent apprehension test, and this is also something we have to take into account. This is another systematic review published in BMC, and as you can see, the difference is in time, 83 minutes, which is, to my opinion, very long for an open procedure versus almost 2 hours for an arthroscopic procedure. All these papers published in the last 5 years reported that the results were the same regarding efficacy of the procedure, recurrence rate, etc., etc. This is another study which compares arthroscopic versus arthroscopic latter Z procedure, and the most, let's say, important find is that the complication rate is higher even with experienced surgeons with the latter Z procedure, and it requires, as we heard before, a steep learning curve with high rates of complication. Another interesting thing we heard before about the fusion rate, 100% fusion rate at 3 months with the open latter Z and 41% with the arthroscopic latter Z. This was increased to 70% in 6 months, but still 35% of the bone did not unite to the glenoid. So this is something also that we have to take into account. What about cost, which is in some countries like Greece an important problem? This study from Pietro Randelli report that it's much higher the cost with the arthroscopic latter Z. This is something, of course, that we know very well, and it has to be justified by the benefit to the patient if it's worthwhile to spend almost double the money to do an arthroscopic latter Z procedure. Finally, it's not all about the dislocation. As we heard before, the arthroscopic bone block procedure in general and latter Z has the highest complication rate, close to 15%, and this is something that make most of the surgeons skeptical to decide if they are going for an arthroscopic latter Z or not. So in conclusion, regarding recurrence rate, shoulder function, there are similar results between open latter Z and arthro latter Z, and I think we all agree on that. So neither procedure shows clear superiority one over the other. Regarding complications, this is higher with the arthro latter Z. It's a low rate complication with open latter Z, especially if you are very cautious regarding the split of the subscap. And of course, the cost is much higher with the arthroscopic latter Z, and time is much longer with latter Z. So in conclusion, why I perform open latter Z? It's a very, very reliable operation. It has a low complication rate, less than 3%, low cost, just 2 screws, it's not a time-consuming procedure, and time is money, as we know. And probably as it was in the past not the rule to do an arthroscopic rotator cuff repair in 2000, probably this is the case with LATAR-Z, and in the future, we really don't know. Maybe this is the case 20 years from now, but only time will tell us if the orthopedic community adopt the arthroscopic LATAR-Z procedure. Thank you for your attention.